Welcome to the Health Momentum Podcast. Today, we are diving into a topic that hits many clinics where it hurts: insurance denials that seem impossible. Have you ever treated a patient, documented everything meticulously, and then received a rejection that made no sense at all? We are going to explore why this happens, what clinics can do to protect their revenue, and how physicians can stay ahead in a system that often feels stacked against them. To help us unpack this, we have a professional medical biller who has seen these challenges firsthand and an expert who knows the ins and outs of navigating the system. Leo, let's start with you.
Thanks, Jane. When I first saw that particular claim denial we talked about, I honestly could not believe it. The documentation was flawless, every single step followed the guidelines, and yet the insurance company rejected it, actually calling it an act of God. I mean, from a billing perspective, it was just utterly confusing and incredibly frustrating. These types of denials are becoming so much more common, and they create huge, just astronomical administrative burdens for clinics, I see how these decisions impact not just finances but patient care as well, and my goal is to help clinics understand these really baffling patterns and prevent these losses before they even happen.
Leo's perspective is absolutely invaluable because it highlights the operational realities behind every single claim. What we're seeing, Jane, is that insurance systems are increasingly driven by categories and automated classifications, not individual patient stories. Rare conditions, unusual circumstances, and frankly, algorithmic flags are triggering denials at a growing rate. Clinics need to take a proactive approach. They need to track denial patterns, flag high-risk claims early, and adjust documentation to reflect payer expectations. Prevention is far, far more effective than trying to appeal after the fact. Physicians who implement these strategies protect revenue, reduce stress on their staff, and maintain their focus on patient care. Understanding the system, anticipating challenges, and advocating consistently is truly the path forward for sustainable practice management.
Act of God, that's just wild. Leo, it almost sounds like a cop-out, doesn't it? How often are you seeing these kinds of vague, almost nonsensical reasons for denial, and what do you think is driving this trend?
Oh, it's not an everyday occurrence, thankfully, but it's frequent enough to be alarming. An act of God is certainly an outlier, but it represents a larger issue. We're seeing more and more denials based on what seem like minor technicalities, or vague reasons like medical necessity not established, even when it clearly is. I think what's driving it, as Dr. Cham mentioned, is this increased reliance on automated systems. Algorithms are designed to flag anything that deviates from the norm, even if that deviation is perfectly justified medically. It creates this huge chasm between clinical reality and billing reality,
Exactly, Leo. And those algorithms, they're not always trained on the full spectrum of human health. They might be looking for certain keywords, certain codes in a specific sequence. And if your perfect clinical narrative doesn't align with their narrow definition of what's normal or expected for that condition, it gets kicked out. It's not necessarily malicious, but it's certainly inefficient and deeply frustrating for providers and patients alike. It forces clinics into this defensive documentation posture, which really takes away from patient interaction time.
So it sounds like clinics are caught between a rock and a hard place. They need to provide excellent patient care, but also essentially speak the language of these automated systems. What are some of the most common mistakes you see clinics making that lead to these denials, even when the care is appropriate?
One of the biggest is under-documentation, even when the physician feels they've written enough. It's not just about what you did, but how you justify it in the payer's language. For example, if a patient presents with complex symptoms and the physician performs multiple diagnostic tests, but the documentation only lists the symptoms vaguely or doesn't explicitly connect each test to a specific, clearly documented medical necessity, that's a red flag. Or failing to demonstrate the chronicity or severity of a condition that might otherwise seem routine. Another common issue is not linking every diagnosis to every procedure. It sounds basic, but in the rush of a busy clinic, it's easy to miss a detailed connection.
I'd add to that, Leo, that clinics often don't leverage data they already have. They might appeal denials one by one without stepping back to analyze the bigger picture. Are certain payers denying specific procedures more often? Are denials clustering around a particular diagnosis code or a particular physician's charting style? Identifying these patterns is crucial. It's not just about fixing one claim, it's about fixing the process. And often, clinics don't invest enough in training their clinical staff, not just the billers, on what payers are looking for in terms of documentation. It's a team effort, from the front desk to the provider.
That's a fantastic point, Dr. Cham. It really highlights the systemic nature of the problem. So if clinics need to be more proactive, what are some tangible steps they can take right now to identify those high-risk claims or patterns before they even become denials?
Absolutely, Jane. First, I always recommend implementing a robust denial management system. This isn't just a spreadsheet. It's a dedicated software or module that can categorize denials by payer, reason code, provider, and even patient type. This allows you to visualize trends. For instance, you might discover that payer X consistently denies claims for procedure Y when performed on patients over 65. That immediately tells you to review those specific claims more closely before submission, or even to proactively engage with payer X to understand their specific criteria. Secondly, staff training is paramount. Equip your billers and coders with the knowledge to identify these red flag situations based on historical data. They become your first line of defense.
To build on that, once you've identified those patterns, you can create internal checklists or cheat sheets for providers. If payer X has specific hoops for procedure Y, let's make sure the physician knows exactly what language or details need to be in the notes for that specific case. It sounds a bit like teaching to the test, but honestly, it's about ensuring medical necessity is articulated in a way the payer system can understand. We've also found success with pre-submission reviews for certain high-dollar or historically problematic claims. Have a senior biller or a coding specialist do a quick double check before it goes out the door. It adds a little time, but it saves immense headache and revenue later.
So, it's about turning those frustrating patterns into actionable insights. I can imagine that implementing these strategies requires a cultural shift within a clinic, right? It's not just a quick fix. How do you get physicians on board with these enhanced documentation requirements, especially when they're already stretched thin?
That's the million-dollar question, Jane. It absolutely requires a cultural shift. The key is to demonstrate the direct impact on their bottom line and their time. When you can show a physician that their documentation habits are directly leading to, say, a 15% denial rate on a certain procedure, which translates to X dollars lost and Y hours spent by staff appealing, it becomes very tangible. Frame it not as more work, but as smarter work that reduces future administrative burden. Providing templates or EMR shortcuts that prompt them for specific, payer-friendly details can also be incredibly helpful. Make it easy for them to do the right thing.
Yeah, and it's also about communication. Billing staff can't just send a blanket email about new documentation rules. We need to sit down with providers, ideally one-on-one or in small groups, and explain why these changes are necessary. Show them examples of denied claims and how a slight adjustment in wording or an added detail would have prevented it. When they see the direct consequence of a small omission, it clicks. We've even tied it into performance metrics or incentive programs in some clinics, where reducing denial rates for their claims can lead to small bonuses or recognition. It helps align everyone's goals.
Those are excellent, very practical suggestions. Let's talk about the dreaded appeal process. Sometimes, despite all best efforts, a denial still happens. What's your advice on effective appeals? What makes an appeal successful versus one that just ends up in another rejection pile?
The first rule of appeals is, don't give up. Many clinics treat the first denial as the final word, and that's a huge mistake. Many payers actually count on that. For an effective appeal, you need to be strategic. Don't just resubmit the same claim. Analyze the denial reason code provided by the insurance company very carefully. Is it a coding error? Is it a medical necessity issue? Did they misinterpret something? Then, gather all supporting documentation. That means not just the original claim, but every relevant patient note, lab result, imaging report, and even peer-reviewed literature if it supports an unusual treatment or diagnosis.
And structure your appeal letter clearly. Don't just dump a pile of documents on them. Start with a concise summary of the patient's condition and the care provided, directly refuting the denial reason. Cite specific passages from the patient's chart that support your argument. If the denial mentions a lack of medical necessity, explain why the service was medically necessary for this specific patient at that specific time. Highlight objective findings. It helps to use a template that ensures all critical elements are included. Also, remember the different levels of appeal. If the first appeal is denied, don't hesitate to escalate to the next level, and sometimes even to an external review.
So, persistence and precision are key. What about those truly exceptional cases, like Leo's act of God denial? When you encounter something so bizarre, how do you even begin to craft an appeal? Is there a point where you just have to cut your losses?
That's where it gets really tricky, Jane. For the act of God one, we actually had to go back and find specific examples of the extraordinary circumstances that led to the claim. It was related to an unforeseen weather event impacting a patient's immediate need for care that couldn't be postponed. We essentially built a narrative around the clinical necessity given the unique environmental factors. It required a lot more legwork than a typical appeal. Sometimes, you might need to involve legal counsel or state regulatory bodies if a denial seems truly arbitrary and egregious. But yes, there is a point where the cost of appealing, in terms of staff time and resources, outweighs the potential reimbursement, especially for smaller claims. That's a tough call clinics constantly face.
And that's precisely why prevention is so critical. If you're spending all your resources chasing impossible appeals, you're not focusing on proactive measures that could prevent 100 other denials. For those truly unique outlier cases, it's often about pushing beyond the standard appeal process. It might involve directly contacting a medical director at the insurance company, or even engaging with provider relations to clarify their specific policies for unusual situations. It becomes less about this claim and more about this type of situation to prevent future occurrences. Sometimes it even requires advocacy through professional medical societies to influence payer policies more broadly.
Arthines Malta. It sounds like physicians and clinics are essentially becoming advocates not just for their patients' health, but also for their financial well-being within a very complex system. What role do you think technology plays in all of this? Are EMR systems and billing software evolving fast enough to keep up with these shifting payer rules?
That's a great question. Technology is a double-edged sword. On one hand, it's part of the problem, with payer algorithms creating these automated denials. On the other, it's absolutely part of the solution. EMRs are getting smarter. Many now offer integrated coding suggestions, real-time claim scrubbing, and even predictive analytics that can flag potential denials based on historical data before a claim is even submitted. The challenge is that these systems need to be continually updated to reflect the ever-changing payer landscape. Clinics need to ensure their technology vendors are proactive in pushing those updates and that their staff are fully trained to utilize these features.
I agree. We're seeing more advanced clearinghouse functionalities too, where claims are vetted against hundreds of payer-specific rules before they even hit the insurance company. This catches a lot of the low-hanging fruit, the simple errors, but for the complex medical necessity or experimental type denials, no software can fully replace a human expert's review and a well-crafted appeal. What I'd love to see is more integration between the clinical notes and the billing side, so that the documentation a doctor naturally writes for patient care can be more easily translated into the specific format payers demand, without requiring excessive extra clicks or separate documentation. That's the dream.
That makes so much sense. Streamlining that process would be huge. Looking ahead, what do you see as the biggest emerging challenges or trends in insurance denials, and what should clinics be preparing for in the next few years?
I think we'll see an even greater reliance on artificial intelligence and machine learning by payers. This means denials could become more sophisticated, potentially harder to pinpoint the exact reason for rejection if the AI's logic isn't transparent. Clinics will need to invest in their own AI-driven solutions to counteract this, using analytics to predict and prevent denials with even greater accuracy. Telehealth and remote patient monitoring claims will continue to be an area of scrutiny as payers solidify their long-term policies for these services. And finally, value-based care models will bring new denial triggers related to outcomes and quality metrics, shifting the focus from just services rendered to services rendered effectively.
I absolutely agree with Leo on the AI front. It's going to be an arms race, honestly. From a billing perspective, I also anticipate more targeted audits, especially for high-cost drugs or procedures. Payers are getting smarter at identifying outliers in utilization data. Clinics need to ensure their internal audit processes are robust and that they can easily justify the medical necessity for anything that looks unusual compared to average benchmarks. The other big challenge I foresee is the increasing complexity of multi-payer arrangements within ACOs or other integrated care networks, where coordinating billing and avoiding denials across different systems can be a nightmare.
Wow, it sounds like the landscape isn't getting any simpler, but the good news is there are proactive steps clinics can take. So if listeners take one thing away from today's discussion, what would it be? Leo, let's start with you for that final key takeaway.
My main takeaway would be, don't view denials as individual, isolated incidents. They are symptoms of a larger system. Analyze, track, and educate. Your billing team and your providers need to be in constant communication, learning from every denial to prevent the next one. It's about building a culture of vigilance and continuous improvement.
And my takeaway is for physicians, embrace your role as an advocate in the business of healthcare. Your meticulous documentation, your willingness to engage with the billing process, and your understanding of payer expectations are not just administrative tasks. They are critical components of sustainable patient care. Protect your revenue so you can continue to focus on what you do best, healing.
Excellent advice from both of you. It's clear that while the system can be challenging, clinics and physicians have powerful tools and strategies at their disposal to navigate these impossible denials. Leo Martin, Dr. Cham, thank you so much for shedding light on this crucial topic and for providing such practical, actionable insights. To our listeners, thank you for tuning into the Health Momentum podcast. We hope this episode empowers you to protect your practice and focus on what truly matters, your patients. We'll catch you next time.